Thank you so much, Dr. Deepa, for the kind introduction. And at the outset, I would like to thank Inarthal for having me here. And quickly moving on to the talk. So, tips and tricks for tips. So, actually, it won't be tips and tricks. It will be more like what's new, what's happening. And just to set the ball rolling, I'll just tell. So we all know in cirrhosis, portal vein is a high pressure system, and we need to decompress it. And how do we decompress it? We place a stent, a tunnel thing through which we create the tips and we place a stent so that it is connected to a low pressure system, and the blood from high pressure system is diverted to the low pressure system, thereby reducing pressure and hence taking care of whatever are the complications, maybe ascites or many more. So these are the indications. We all know that acute esophageal variceal bleeding, refractory to medical management, prevention of variceal bleeding, refractory ascites, hepatic hydrochloride, but so these are the things which we know since long that these are the indications and we have been working on it. But before going to tips, we all should know what are the indications and predictors of outcome. So most important is cardiac disease, and why we talk about cardiac disease. Ultimately, you are taking all the blood towards the heart. So if there is a cardiac disease, you are flooding the heart with more and more blood. So your heart should be good to pump all the blood what it is receiving. That's why that's very important. You all should be very careful about it. Similarly, pulmonary hypertension. And if we talk about contraindications and predictors of poor outcome, so if we talk old age, so it holds true all across the globe. But if we talk about India, we should be more careful. Indian patients are more frail, fragile, and what we do is morely a rescue tips. We do tips as a last resort. When everything is exhausted, then we do tips. And that time, the patient is already sarcopenic, old age. So there are many factors which will have an adverse effect. But old age should be taken care of. Hepatic encephalopathy, we all talk. Though there are data coming where they say hepatic encephalopathy may not be the only thing as a contraindication, but still, I personally feel in India because patients are sarcopenic, any history of HE should be taken. It should be seen with a lot of carefully and accordingly. Bilirubin 3, more than 3 should be careful. And MELD scores definitely. It's not MELD sodium. MELD score more than 18 is associated with high mortality. Again, we need to know. But having said that, sodium still plays a role because these are sodium depleted patients. So sodium has its own place. So I'm not telling that MELD sodium should not be seen. But what MELD we talk about in tips is the original MELD, where the MELD score is calculated and that should be less than 18, then you have a better outcome. We generally measure portal pressure gradient while doing tips. Like we go into the RA and IVC, there we measure pressure and then we take a portal pressure, measure the portal pressure, and then we subtract what is the IVC pressure and that is the gradient. And our aim is to reduce the pressure and bring it to 12 millimeter of mercury, or at least reduce by 20%. Sometimes some literature says 50%, but it should be 20%. So how we do? So very simple. We go into the hepatic vein. This is the hepatic venogram in the first image if you see here. Then we take all our assembly. This is a cannula. There is a needle into it, and we take it, advance it up to here. Then we target the portal vein, and nowadays we have a luxury of having an ultrasound. So we do an ultrasound, and through that ultrasound we guide our needle into the portal vein. We puncture the portal vein, and then we have this picture where the catheter is there into the portal vein. We put some contrast, opacify the portal vein. Now we are sure, yes, we are into the portal vein. Dilate the tract. So because it was a needle, we need to dilate the tract, make it large so that the stent can fit in. And then we measure what size of the stent is in place. So there is a marker pixel where there is 1 centimeter difference between all different marks. This is how you calculate and you place the stent. And this is how it looks. So previously you were seeing many collaterals over here. Everything goes on, and now the flow is directed from the portal vein into the IVC and into the RA. And that's why cardiac function is important, because you are diverting and taking all the blood flow into the right atrium. How do we measure the success? So it is categorized in 3, like technical success, hemodynamic success, and clinical success. So first we are able to do a successful have achieved the hemodynamic success. And finally, achieving technical and hemodynamic success is not the primary thing. We are concerned about the clinical success. So if there is any, rebleed or other things, then that means there is a tip failure. So we should achieve that there shouldn't be any rebleed, or in cases of ascites, the ascites should go. Now, what are the recent concepts? These are the things which we already know, which has been discussed in past thoroughly. What are the recent concepts? So recently we are talking more about early and preemptive tips. So it started in 2010. We talked. It was known as early tips. Now we talk and we use the term preemptive tips. Then another term, that is rescue, similarly salvage. So rescue and salvage is another new term which is being used to rescue and salvage tips. Now there is another thing coming up. What should be the diameter of tips? Shall we come down? So initially, whatever study was there was with 10 millimeter, but now we are talking about 8. And in fact, if we see the literature, it has come down to 6 as well. Now, coming to ascites. So these are all true for first 3 is for variceal bleed. But if we talk about ascites, then shall we do an early tip? Yes, literature is saying that. Yes, we should go for an early tip. And shall we do a small diameter tips for ascites as well? So literature is divided. People say that the results are better with 10 millimeters. But if we want to have less incidence of hepatic encephalopathy, we can bring to 8 millimeter. And if you combine it with proximal splenic artery embolization, and I'll quote that article and show it. Another new thing, tips for portal vein thrombosis. So again, that's new thing which is coming. Tips for extrahepatic portal venous obstruction. So that's new. Previously, both of these were considered as a contraindication for tips, which has become an indication. And this is the recent thing, and probably people are trying to do more of it, such kind of procedures. So preemptive or early tips, this is the landmark paper 2010 NEJM and the Spanish group led by Dr. Garcia Pagan. And he beautifully showed that if we compare tips with the drug plus only endoscopic band ligation, so early tips definitely gives a freedom from uncontrolled bleeding or rebleeding. And survival, then also if you say this is the survival and this is rebleeding, so absolutely no rebleeding, survival is much better as compared to drug plus band ligation. But this was a RCT, so a very controlled group. So just to prove their theory right, they did a post-RCT surveillance study. And again in this surveillance study, they showed that it actually worked in real world scenario as well. So it is not only the RCT, probably real world also it works well. Then moving ahead, this was 2010, 12 and 9, 2019. Again, this was a multi-center observational study. And they again showed that preemptive tips improves outcome in high-risk variceal bleeding. And they said that CTP-C or CTP-B plus AB preemptive tips. So this was the time when first preemptive tips. So early tips was replaced by preemptive tips in 2018-19. So this was the era when we started calling it as a preemptive. So preemptive tips decreases uncontrolled bleeding, rebleeding, and worsening ascites. So whatever you talk. So it is going to help. Tips should be done early. So this is what we know. Now, this is a very interesting paper. Again, rebleeding and mortality risks are increased by ACLF, but reduced by preemptive tip. So here, authors are trying to prove that if you do a preemptive tip, probably, you are reversing the ACLF. But mind it, this ACLF is a definition given by the European Society and not by the APASE. So there is a change in definition. But we should, see this beautiful paper where they say that if there is a acute variceal bleed, the patient will get into ACLF. If you do preemptive tips, definitely that is going to help the patient and reduce the mortality. Again, coming to another terminology, that is rescue and salvage tips. So rescue and salvage tips is mostly done in India, and this is what we are interested in, what we do, our practice. And this paper is from our group, where we analyzed 672 patients, where we had 121 patients who had recurrent variceal bleed, for which one group went into emergent tips. And emergent tips was actually done within 24 hours of bleeding. That is, they presented to emergency within 24 hours, they underwent tips. The other group went to the covered esophageal stent, that is Essex-Ella, Danis-Ella, whatever name. So the only one company, Ella, makes it. So Danis-Ella stent. So it was a matched group. Then in emergent TRIPS group also, we also further categorized those who underwent TIPS only within 8 hours. Endoscopy, spurter, unable to control, they were moved to our cath lab. We did the TIPS. Another where patient was stabilized first in ICU and then sent for. So both the groups were compared, and what we saw. So if we see TIPS plus D group, so this is the both the group matched. We can see the TIPS group has a much better outcome, and if we see the group which is a matched group, propensity score matched, PCM matching, again we find that the TIPS group has a much better outcome. And now comparing very early versus early TIPS, so definitely those who had very early TIPS, like as soon as the bleeding started and we were sure that we are unable to control by endoscopy, then we did a TIPS rather than stabilizing them, sending to ICU, again bringing them back and doing a TIPS. So those who had a very early TIPS, maybe within 8 hours, had a much better survival. So as soon as you know you are unable to control, please get a TIPS done, because once there is a hemorrhage, gradually every parameters are going to worsen, right from kidney to lung to everything, and that's difficult to control. So better not to get into a vicious cycle, and we should do it. So this is what is concluded, that 8 hours is better. And if we compare TIPS with Danis-Ella, TIPS has a better outcome. 8 versus 10 mm, again, there is a data where we say that shunt dysfunction, that is stent dysfunction, both are similar. Rebleeding, 8 versus 10, similar. Hepatic encephalopathy, 8 had much lower incidence of hepatic encephalopathy. So with this paper, we know that 8 compares very well with 10 and has a lesser hepatic encephalopathy. Coming to ascites, so this is a cost-effective analysis. Again, we know that early placement of TIPS is cost-effective, the paper says, as compared to large volume paracentesis with albumin. And this is what I was talking about, small diameter TIPS combined with clinic artery embolization. What this have seen that the 10 mm TIPS was associated with worse encephalopathy, so it was able to control ascites better. But 8 mm TIPS, if we combine with splenic embolization, and how do? We do a proximal splenic artery embolization and not a pulse embolization, no necrosis, only just reducing the splenic arterial flow, thus reducing the splenic venous flow, and hence reducing the portal pressure. So you are reducing portal pressure by reducing the splenic flow. Simultaneously, you are placing a small stent. So you are reducing pressure and you get the same result as what you get with a 10 mm TIPS stent. And so this may be a concept where you cannot place a 10 mm stent, place an 8 mm stent and do a proximal splenic artery embolization. Now coming to TIPS for PVT, this is a cirrhotic case. You can see a portal vein thrombosis, we did a TIPS. So this is possible, we can do it, and should be done in all patients who have failure and those who don't respond to anticoagulation. This is our paper, not going into detail, so in the interest of time. So we have proved that it works very well. So wherever anticoagulation does not work, we can do a TIPS. Gastric variceal bleeding, ideally, if you ask my view, I'll say that we need to obliterate the varices and not do a TIPS. But again, Spanish group is very much for TIPS, and they do a preemptive TIPS for uncontrolled gastric variceal bleed. This is one of the keys. If still you have to do a TIPS, you have to do an anti-grade embolization. Here you can see these are the varices which you bleed. So if you go inside, take your catheter inside, put coils and glue into it, obliterate the inflow so that no blood flow is into the varices. And this is how it looks. So now you have already embolized, all the blood is diverted. This is the Spanish group again. So they are so much fond of TIPS, they do TIPS for everything. So data is definitely there, but as an Asian, we don't agree with it. We are more towards PRTU and we can do for EHPV. I'll just quickly show you one example. This is a complex case, blood carry with EHPV. This is how the ultrasound looks. This is the CT scan. You can see EHPV and blood carry. So we went inside. First we were into a collateral. We later realized this is a collateral. This is the portal vein which is occluded. We went, we struggled, then we were able to get into the SMV as well as the splenic vein, we dilated both the system and finally established it. So in EHPVO you can do this. For stomal varices, again you need to obliterate the varices and do a TIPS. Hepatic encephalopathy, what you can do, you can reduce the TIPS stent. Here we have reduced the TIPS stent, and rarely you may require to occlude the TIPS. With this, I come to the end of the talk, and the conclusion is TIPS improve survival and reduces portal hypertension complications in patients with acute variceal bleed and refractory ascites. Early and preemptive TIPS is associated with improved survival. Emergent or rescue TIPS done within 8 hours has better survival, and MELD plus lactate determines the 6 weeks mortality. That's why you shouldn't let the MELD and lactate increase. Do early TIPS as early as possible, maybe within 8 hours. 8 mm TIPS is associated with reduced hepatic encephalopathy. TIPS is a preferred treatment in patients with Budd-Chiari syndrome with non-recanalizable hepatic vein IVC, we know that. And other indications for TIPS include management of portal vein thrombosis, EHPVO, and ectopic varices. Thank you so much for your patience.
Thank you very much for briefing, Doctor. But I just wanted to learn opinion regarding the newer sequence site of standard 60 kilometers.
Yeah, so that's a very good thing to happen, and probably we'll be having it. BARD has that 6 to 8, and GORE has 8 to 10. But there are certain situations where you know that you can't afford to have a larger stent, and there is a study coming from, especially from the German group, where they have placed 6 millimeter stent in a atrophied liver, where a very small liver, where MELD score is high, the patient is bleeding. Ideally, TIPS should not have been done, but what they did, they placed a very small tip, 6 millimeter tip, and they showed that it was able to control the bleed more so. The complications of TIPS were also not as much as expected. So in such a scenario, you couldn't have placed ever at 10 millimeter. 8 to 10 or 6 to 10 is always good for ascites stents. So that's, yes, if you talk about ascites, I'll say that should be the way to go. But if you talk about variceal bleed, once you are able to control it, and then the patient is in beta blockers with and other supportive therapies, probably that will work. So we are not much worried about variceal bleed. It's more of
enjoyed your talk, very educative. But the question which I have is that it takes time for the ascites, refractory ascites, for after the TIPS it goes off, right? At that point of time, when do you think that it's been a failure, that is not taken care of the hemodynamic part? Stent is patent, you keep doing that one, then but there are some 10 to 15% of people do not respond at all to this one. Can we upsize in that case in people who are only child B, who are not child C?
That's a very nice question, and thank you sir for asking that question. So yes, normally after 4 to 6 weeks, still doing all maneuvers like taking care of kidney, taking care of heart, because these are the two organs which you are dependent. TIPS is only is a conduit. Ultimately, you are begging heart and kidney to function more to help you out in taking the fluid out. So that lymphatics, are the lymphatics really working? So these are the total 3 scenario which is going to take care of everything. 6 weeks is a good time. Second, can we actually take out all the fluid? So can we do a LVP of more than 5 liters? And can we admit and put a catheter drain and quickly dry it? So those are the things which we need to see. If that can be done, again we need to see if midodrine is working or not. If none of the medical therapies work and still there is no signs of hepatic encephalopathy, we can think of putting a parallel stent. That is also best. But that scenario is less because where if you try all these measures and everything fails, then probably we can say it is failed. But yes, coming to splenic artery embolization is again silver lining, where you can further reduce the pressure without increasing the flow or load to the heart, just reducing the arterial flow to the splenic parenchyma, hence reducing the splenic outflow and reducing the pressure. That also works good When we don't have an option of tips, and we are actually doing a study on it, where we are doing a proximal splenic arterioembolization, no pulp embolization, no necrosis, and patients do respond. Their frequency for LVP goes down. In fact, many times they don't even require to do it at mid part. Once you know that all the pancreatic arterial arteries are preserved, that is
Would you put a plug or a
plug and glue both.
glue doesn't play?
Plug after a plug it will
So after
stick.
plug, you just put the stick.
Yeah, just a 0.1. Just do
What
just.
size plug do you normally use?
Normally AVP4. If it is not possible, then we use multiple plugs.
And also, Dr. Amar, regarding the stent size, it was asked for 6 to 10. Then the current Viator stent, if you put a stent, but then you dilate the tract only up to 8 mm. 8 mm. It works as an 8 mm.
Normally, yes. So if you don't dilate, especially at the portal venous end, so that itself is a very tough part. So that works well. So that is the hourglass. But the problem with that is many times the thrombus formation building up starts at that time. So if you follow it up, probably in a year or so, you'll find that the tip is showing some thrombus formation and probably occlusion as well.
Okay, and at what point would you be worried about sarcopenia as well? Because sometimes you do take sarcopenia index as well for
Yeah.
risk of encephalopathy.
Yeah,
or anything like that.
that's very important, and we always take it. Nowadays, we see the CT scan and we have certain indices, so we look into it and accordingly we explain the patient. If there is no other options, we still try to put a very small stent, but yes, we are very careful.